patient support group meeting on behalf of the ISBMT. And I am your host, Dr. Venkatesh Igbote, joining in as a clinical hematology and BMT specialist.
Hello, Dr. Venkatesh. Yeah.
Please unmuted.
Hello.
Shall I continue? Or shall we give it a minute?
We'll wait for a minute, ma'am.
Okay.
Revati, ma'am, if you can continue, please, ma'am.
Oh, thank you. So sorry about the technical issues we've had. So welcome everyone to the patient support group meeting, and it's our pleasure to host this program today. And the patient support group was formed originally by the president, Dr. Sashi, Dr. Tapan Saikia. Next slide, please. With the help of our secretariat, so that we can give have meaningful interactions with the patients, what they have, what are the issues and what we can do for patient advocacy. And Dr. Venkatesh Ekbote, Dr. Silky Jain and Ria and Suman Kabal are the people who brainstorm all of these sessions. And it's my real pleasure today to welcome and introduce Dr. Ramanan. He's been a friend for over 2 decades and one of the most charming medical oncologists I've ever met. And CML is one condition I think that has pioneered with regards to patient support groups, and people like Nags and Miss Vijay Venkatesh, we have been friends for so long. And what are the issues with regards to patients and their community? I think none better than this group to discuss and take things forward. But this is a niche area what we are dealing with regards to transplant. So to give us a background on CML and what are the transplant related issues, we have Dr. Ramanan here today, who's a senior consultant at the Apollo Cancer Center, Chennai. And after which we have a star-studded group of panelists who will be taking us through the questions which are important for patients. Over to you, Dr. Ramanan.
Namaskarams to all. Thank you, Revati, for those kind words, and the organizing committee, ISBMT, for this invitation. So, as the talk is mainly directed towards patients and the family support, the caregivers, I thought I will take it in a simplified way, the whole matter. We will start with a small perspective in 2001-2002. So there was a young man who was planned for BMT. There was a lot of excitement in the unit because Not many allogenic BMTs were happening, a few that was happening. And I had mixed feelings. Why? Because I'd applied for the DVAC program, the MAX program, but this man was not fulfilling the criteria. And but the team was excited because we had a full match house, and he was moved for the transplant to start by late in the evening, and he was stationed next to the BMT room. And then by 6, I got a fax that he has been cleared for the GPAP program. So I remember still now me running up the 3 floors and telling that he does not need a transplant. I didn't know whether that was the right decision at that time. Some of my team members were disappointed because the opportunity to transplant in those days. But the good thing which happened is, even now, that young gentleman, now obviously he's around 40, 45 years of age, is doing very well with imatinib Gleevec. So my opening thoughts to this gathering is, I hope no one ever goes to transplant. So this would be my very initial thoughts. Having said that, we know from the studies which took place in 1999, 2000, we have information for 25 to 26 years, that 60% of those patients started on treatment, they remain on the same treatment. 40% there is a change of treatment. In that 40, 20 of them, by changing medicines from first generation, second generation, third generation, or newer drugs, we are able to once again control the disease and patient is all right. It is that remaining 20 out of the initial 100 which started, that our treatment somehow over the years become ineffective, and he or she becomes a candidate for alternate treatment like transplant. So, but I feel personally that this is information coming from treatment started 15, 20 years back. Nowadays, with more and more options with the drugs, and in medical language, it is called as embarrassment of plenty. We have so many drugs to play with. We are able to risk stratify better. We are able to monitor them more regularly, for example, by 3rd month, 6th month. And we know that by changing our treatment, we can get better results. I feel with the newer drugs, there is information that almost 80 of them go into a complete cytogenetic response by 1 year, as opposed to 65 in the imatinib era. So fewer people may land up to transplant. What, as a CML patient, I would do? So if I am a CML patient, I would not know, I will hope that I am in that 80, 85, but I would not know whether I am in that 5 or to 15%. So I would say that every CML patient from the time of diagnosis should prepare on 3 fronts. Physical, because if at any time we need transplant, we need to be physically fit. So I would say that, whatever that is, exercise or lifestyle changes, healthy eating, make sure that we are in good physical condition. And obviously, it is going to help us for hypertension, diabetes, and for cholesterol. And it would keep us fit if there is need. Second fitness for these patients is the emotional fitness, which is called as the emotional quotient. This is a very, very difficult thing. And all of us, for example, emotional quotient can be improved only by spirituality, by some interest in spirituality. Someone like me, I may become this age, and still I might not ask a deep question regarding myself. But someone who has CML, who has been given a diagnosis of leukemia, chronic myeloid leukemia, obviously would have spent time thinking, why me? what is the reason, what is life after this. And all patients with malignancy do develop a good spiritual bent of mind, and spiritual fitness, mental fitness is going to be very, very important when an individual is going to go for transplant. Right from staying alone for 3 to 4 weeks and various lifestyle changes for a length of time needs extreme mental fitness. Third thing, if ever I have to go into transplant, then I need to ensure that I am financially fit. This is once again very difficult. If I go and say, I have CML, give me insurance, possibly I'm not going to get. But there are centers, there are insurance nowadays which accepts a cancer patient. So, moment an individual gets CML, after some time he should get in touch with these agencies, get themselves enrolled. They will say CML is not covered. We should say no problem, cover BP, sugar, heart problem. Once for 3 years they are comfortable and there is no CML activity, obviously the doctor can give a letter and then they will cover even for CML, even for pre-existing disease. But some amount of homework and time has to be spent to get to the right insurance. Then third, who are the individuals who are going to need a transplant? Like one whose disease phase has changed. Some individuals of chronic myeloid leukemia may present in a very aggressive phase at presentation called blast crisis. Or some of them, their phase may change from chronic phase to accelerated phase. This disease has 3 phases: the very common chronic phase, the aggressive accelerated phase, and a very terminal blast crisis. So if any individual unfortunately is in accelerated or blast crisis, they will almost always need a transplant. Then what is in the patient who is having the routine chronic myeloid leukemia in chronic phase? Then people who have progressed with one change, second change of drugs, third change of drugs. Suppose that the molecular response is getting lost, cytogenetic response is getting lost. We are making appropriate changes from first generation to second generation to third generation to newer. So beyond third line or beyond fourth line, I think the medical practitioners will definitely start discussing with this patient whether it is a right time to do a transplant. Also, some of us with CML, some patients would develop some unusual mutations which are generally resistant to drugs. There are drugs even for those resistant mutations, but that also getting some, unfortunately, some abnormal mutations may select out these patients for transplant. And finally, there are patients who are intolerant. All of us in the GPAP program know that 15, 20 years, there have been young individuals who are having hemoglobin of 5 or 6. Right from their youth, now to age of 40, they are managing. But just imagine how difficult their life is presently due to this. And some of them are intolerant. We keep changing the drug, first generation, second generation, third generation, but they are unable to handle. This small subset of patients may, after detailed counseling, also become a candidate for transplant. Then, once we have decided that the individual is a candidate for transplant, we have to make one important search. That is, which is going to be the appropriate donor. So, the donor search can begin, and mostly they would like to have a search from the immediate first degree relatives. The maximum match will be between the siblings, and extended core search can be there, where we have to match the HLA antigens. HLA antigens are antigens which are present in almost all our cells. And this is a very important evolutionary pathway. And this is there in our system to protect us against bacteria and viruses, so that we can identify bacteria is foreign to us, virus is foreign to us, and then we can eliminate them. This elimination is done with the help of the HLA system, which is quite a complex system. And we inherit 6 of them from our father, 6 of them from our mother, and we express all these 12 antigens on most of our cells. And if there is a mismatch between the donor and recipient on this, it leads to a lot of difficulties. So matching for the houses, just like horoscope matching. If there is full house horoscope matching, generally they say marriage will go on well. There could be small issues that is called as mismatch between the minor transplant antigen. But if there is a major mismatch, half or matched but unrelated donor, then we are bound to expect more and more problems. But with increasing scientific knowledge and availability of newer medicines, the transplant physicians are able to do a transplant with half a match called haplomatch, matched but unrelated donor. All these things are nowadays possible with special technique, special training, with anticipated more problems around the transplant time. Then the preparatory phase. For example, if I say tomorrow in Chennai, Sunday is there, some 10-kilometer run is there. Almost every week, some 10-kilometer run is there. And if somebody says, I will start running tomorrow, it's not going to happen, because in the next 2-3 kilometers, he's going to have all the problems. So he needs to be conditioning himself. So same way, the recipient's bone marrow has to be conditioned. And the treatment which is given to him at that time is called as conditioning regimen. At the same time, from the donor, adequate amount of stem cells, preferably or most commonly from the blood of the donor, they will collect the stem cells and keep it stored safely. Then, after seeing that the patient is fit, after getting all the medical clearance, he or she will be started on the conditioning regimen. This is to condition the bone marrow, just like we have to condition our body for a 10-kilometer run. We have to condition the bone marrow. That is, most of these diseases are bone marrow diseases. So we have to eliminate that. That comes from the myeloablative or white cell destruction by the treatment. Then the another thing is we have to suppress the immunity of the patient. Suppressing the immunity of the patient is for 2 reasons. A, patient's body or marrow should be ready to receive the donor's graft. Even though the horoscopes are matched well or they are not matched well, we need to ensure that the recipient does not reject the donor. So that is called as transplant rejection. It is a dreaded complication, but fortunately very rare. Nowadays we are not seeing that, because of we are able to collect good amount of stem cells. We are able to have good cryopreservation technique, and that is not a common phenomena. But if you don't suppress the immunity of the host or the recipient, he or she will reject the graft, which is a dreaded complication. The next thing which we do by the immunity suppression or immunosuppression is the graft after settling down, the donor's graft after settling down into the recipient. For the graft, the recipient is foreign. Because even if you have a very good match, there are minor mismatches. And many transplant nowadays can be matched unrelated, could be haplo-identical. So there is a difference between the immune system of the donor and the recipient. So the donor immune system, after going and settling down nicely into the patient, into the recipient, will mount a response, an aggressive response against the liver, against the skin, against the intestine, against any part of the body. And this is called as graft versus host disease. This is a very important and serious problem. But it has a double-edged issue. If you completely suppress the graft versus host disease, there is a slightly increased, a definite increased chance of leukemia to relapse, because the same immune system which is attacking the recipient's body, the same immune system helps to clear the unseen, the cells, the malignant cells which are still lingering, which are dormant, which are not replicating, which have not been eradicated by the myeloablative treatment. The immune system will clear. So graft versus host has problems. But the same thing causes graft versus leukemia, which is very much advantageous for the patient. Then once the infusion is done, the conditioning regime may be for about 4 or 5 days. There will be various methods are there, one with very high doses. If the patient is slightly old, has medical problem, with less doses, one is called myeloablative, one is called reduced intensity. There are various names. That is for the doctors to decide on which conditioning regime to use in that particular patient. Then what will happen? The stem cells which are taken and kept outside, after the conditioning regime is given to the recipient, they will give 1 or 2 rest days so that all the medicine will come out through the urine or come out through the liver. And now they will give this stem cells back to the patient through the IV line. This patient will have a IV line in the neck, which is called as a central line will be there. It will be a silicone central line, which will be there with the patient for about 6 months. And by certain homing mechanisms, just like birds which are migrating, they again go back to the same place, always come to the same place. When the stem cells are given by the vein, they go back to the bone marrow and settle down and start repopulating the system. So around 10 days or 12 days or 15 days, they settle down and repopulate. There are some criterias, and then they will say that the donor graft has engrafted. When platelets become stable, 20,000, or the neutrophil counts become more than 500 on 2 days, they will say the graft has settled down. So this is one very important time. The doctor's anxiety will come down the moment engraftment takes place. So they know the procedure, initial part has gone off satisfactorily, and then they will look for the other problems which will be coming. So the next 90 days is fraught with all types of problem, infection, graft versus host disease, which I mentioned, which can affect any organ like lung, liver, intestine, skin, etc. And lots of problem. So now we need a dedicated, this is very, very important, a caregiver outside. And remember, this caregiver should not be changing. Every third day, new caregiver should not come. Because when new caregiver comes, when the transplant doctor will come for reporting and tell him in the morning, he will ask, what is CML? What is this graft versus host disease? So the doctor will lose his cool. He will not want to again start the same discussion again and again. So one caregiver is there. He or she will get very well educated, and they will know many things which most doctors who are not in the field, they will never know. They will know many terms which most doctors, a cardiologist will not know any one of these terms, but the caregiver and the patient will know most of the things. So we need a good, constant caregiver. That is very important. Then couple of caregivers outside. They should be dedicated only for running for blood, because we have very unusual things. We will say in the middle of the night, I want to give platelet. At that time, if you come and say, Adil, not there, this, that, donor is not there, means we really get agitated. So my sincere advice to the patients and family, you should have a good, the hospital is going to support, there is no doubt. Hospital knows they are going to support. But you should not be going back to the treating doctor, blood is not there, I don't have, donor is not there. If you bring this point, we become very uncomfortable. So make good arrangement for donors. Third important thing, when this crisis is happening, like the first 30 days, 60 days, 90 days, 100 days, this is a very, very, very important time. And once you cross 90, 100 days, doctor also relaxes. And once 6 months is over without much problem, the transplant doctor may also say, now you can go back to near your place and we can handle you. All those things will happen. But remember, in between, particularly remember, if patient is very unwell, at that time, family members should not come directly and keep talking to the doctor, finance problem, finance problem. If you keep talking like that, we don't want to get influenced, but as doctors, we get influenced, and sometimes we will try to cut corners, which is not all right. So you should approach medical social worker will be there other than doctor. So when you go and tell your finance problem to the medical social worker, that medical social worker will tell us the problem in a relaxed time, not when we are seeing the sick patient. That time, aram se, we will be able to give some proper answer. So these are very important things which the family and patients, they need to understand. Need a keep constant people caregiver. Two, very important, blood, keep a whole battery of people running for it. Finances already has been discussed very well. In between spikes, go through medical social worker. Don't try to cloud the mind of the doctor. Then once 6 months are over, and slowly there is one another very important problem called as chronic GVHD, which is a very unwanted problem. It will really bring down the quality of life of the patient. The eyes tearing will become less. Oral, taste will not be there. Dryness will be there. Skin, itchy. Skin will become dark, thickened, and we keep on getting some cold cough infection, lung infection. We keep on have to come to the hospital up and down. Can't go out. So all these issues will be there. So that's why I told in the beginning, lot of mental fitness. And another important thing is, though the endeavor of the transplant physician is to not only eradicate the disease, but to completely integrate you into society as a functional individual. That is the aim. But remember, you have gone through a very complicated treatment. You have gone through very unusual side effects and problems. You need to understand that this is new normal. You cannot say, I'll go in the sun and play cricket, means you will get into more skin GVHD problem. Or no, food is not tasting, I cannot do this, I cannot do this, I'm getting fit. Yes, we want to ensure that you don't get these problems, but you need to understand that you are alive, you are free of disease, and you need to make some lifestyle adjustments. Then slowly things will get normalized. So this is a very important message which I wanted to give to the patient and caregiver. Though there are lots of points, obviously, which would have gotten missed out, but I will just finish by a recap. With the present day, most individuals should not reach for transplant in chronic myeloid leukemia. 2, never forget to get the BCR ABL done, because 5 years over, 6 years, 3, everything okay. No, always do. Okay, doctor is busy, not able to meet. No, you get the test, you send it to the doctor, because the rule is we should do the transplant not when your phase has changed. We should always do the transplant when you are in chronic phase. When there is slight increase, when you have finished 3 or 4 lines of treatment. So make sure that you are always checking and sending this report to the doctor. Don't have to think you are going to go for transplant, but like any individual, healthy lifestyle, spirituality, and for me or for all the doctors here, we also need to make financial planning. So have the finances planned. The search for the donors is more a responsibility of the doctor. They will search which type of donor to use in this individual when a matched sibling is not available. That also is a medical decision. And the side effects, possibility of loss of life, that is definitely a shared decision making. We need to understand that there is complications, there is a long stay alone, and there are medications to be taken for at least 6 months. And the aim is to get you back in shape, but you need to adjust to the new normal. Thank you all for the patient hearing.
Thank you very much, Dr. Ramanan. It is a privilege that you could give us such a lucid explanation for the entire journey, right from selecting the patients, their indications, and right up to very important pointers and salient advice that patients need to follow in this entire journey of treatment. And now I move this journey forward. Uh, we have with us friends of Max Foundation trustee, Mr. Nagendran Nagarajan, who would be a moderator of a panel discussion, which will have our esteemed panelists. Now I welcome them, Dr. Pravas Mishra, Head of Medical Oncology and Hematology at Amrita Hospital, Faridabad. He's the BMT physician, apart from Dr. Ramanan, who will be joining us as the panelist. We also have Dr. Jasmeet Kaur. She is technical director and a ACE hematopathologist at Lal Path Laboratories. And also, like Sir alluded to the mental preparations, we have the privilege of having Ms. Ria Daruwala with us, who will be advising us upon how we can be formally prepared with this change of the normal that we experience through this. We also have with us Dr. Lakshmanan. He is head of Department of Hematology, senior consultant at Apollo Cancer Center, Chennai, and he'll be answering questions related to donor stem cell apheresis and the procedure that stem cell donation entails. And over to Dr. Nagendran, Mr. Nagendran, for starting your panel discussion.
Thank you, Dr. Venkatesh. And we have just had a wonderful session by Dr. Ganapathy Ramanan. When he speaks, he gives all the length and breadth of the approach towards BMT and full comfort feeling for all of us. Most of our questions are, in fact, answered. It's a privilege to hear him. So let us start our panel discussion. Thanks to ISBMT for setting up this panel discussion with eminent and esteemed doctors of this country. Warm welcomes to all the doctors, and thanks to every one of you for availing yourself for this session in spite of a busy schedule. I thought of starting with an introduction, but I think Dr. Venkatesh has given a brief good enough. And I quickly introduce myself. I am part of Friends of Max as a trustee. We are there for last 20 plus years in the cancer care area for the CML and the GIST patients. As all of you must be knowing, we are creating so many patient support groups, meetings, and multiple activities related to how to bridge the more connect between doctors as well as the patients. I am a caregiver for last 25 years almost, and it's been a wonderful journey. And thanks to ISBMT to give this opportunity to moderate this session as well. All right, I'll straightly go into the, thank you. I'll straightly go into the questions and answers. As I rightly put up, Dr. Ramanan has taken us through full journey of this, and some of the questions already been answered, but please forgive me if I am repeating some of the questions for the benefit of everybody in the session right now. Thank you. So let me start with one question that we already have answered, but make it much more easier to start on. Dr. Ramanan said that what's the time for doing the, when a candidate is ideal for a transplantation, the disease progresses, or its phase changes, or the patient is intolerant, or resistant mutations happening, right? So when we look at that way, I'm going to ask this question to Dr. Prabhas Mishra. What's the ideal timing for a transplant? Is there a difference based on the age and disease status?
Okay. So what is the ideal patient candidate for a transplant? So generally, age is not a factor when we are taking up for a transplant. Yes, an older person, somebody who is older than 60 or 65, we may not be taking up for transplant, but age itself is not a limiting factor. It is more the fitness of the person that is important when we are taking up for a transplant. Otherwise, the ideal person who's, if let's say everything is fine and the person is fit, then ideally the person should be in a chronic phase. And again, this is for somebody that we have already assumed is a candidate for transplant. I mean, long time back, before imatinib came into the picture, one of the most common indications for a transplant was actually chronic myeloid leukemia. Thankfully, that has come down, and hopefully we should not see much of that. Once we have got the newer drugs, yes, the indications for transplant in chronic myeloid leukemia have been coming down. But an ideal person would be somebody who is young, fit, and is in a chronic phase.
All right. Thank you. Thank you so much. I have one relevant question also on that. Do I have to do bone marrow test frequently to check the disease status? That's a question to Dr. Ramanan or Dr. Prabhas. Both of you can answer. So I'm just repeating. Do I have to do the bone marrow test frequently to check the disease status?
So this is after a transplant?
After a transplant, yes. How frequently I have to do it? That's correct.
So I don't generally do a bone marrow test after a transplant. I would follow up the person with either with chimerism as well as by BCR-ABL testing. I don't do a bone marrow test after the transplant.
Right. Right.
Great.
Any other views? Just want to hear.
Yes. So we can move to the next question, but like sir said,
the slides are not moving for me. Okay. Now finally they're moving.
If you can move the slides, yes.
I'm just going to skip, following the routine, but that will be easier
You can
also.
move to the next slide. No problem.
Sure. That's okay. All right. I want to ask Dr. Riya, because this is like Dr. Ramanan said, it's physically fit, emotionally fit, apart from financially fit. Okay. How you have seen what mental health challenges myself or my family have to face during the process? Can you share some of your experiences, ma'am?
Sure. Thank you, for that question. So, It's important to know that all these experiences are very normal and that you can have a range of emotions. There's not just one way to respond to this. So many families or patients may feel some amount of anxiety, they may feel sadness, they may feel anger, they may even feel guilty. And that's okay because, being faced with something like decisions about BMT or CML and, how to go further is a very big life changing decision. So even though you may be worried and you may be worried about things like side effects, survival, caregivers may be burdened financially, it's important to know that it's all valid and that there are people around who can help you. So these are some mental health challenges that you may face. Of course, there can be many, many more. But whatever you're facing is fine. And there are multiple people who can help you to kind of deal with them and, process these emotions better.
Okay, okay. Dr. Ramana also spoke about the caregiver support, definitely. How do you manage the fear and anxiety about the transplant? So treatment itself is a bigger anxiety and concern for most of the people who undergo BMT before even start the process. So that your answer has, in fact, clarified both the questions I have. All right, thank you. And I'm going to ask Dr. Lakshmanan. Okay, and maybe this I'm going to learn more also from this. What donors should know about stem cell donation by apheresis? Dr.
Thanks for
Lakshmanan.
inviting me, and I'm happy to share this small bit of knowledge which we have. The donor first should realize that it is a life-saving procedure, and his involvement is absolutely essential to save his brother or a sister, or even he can be an unrelated donor also who's saving a life in some other part of the world. So that ability to selflessly donate his own stem cells for a noble cause should first reach his mind. And I think what Ramanan said, you have to emotionally frame your mind to go into the donor attitude and give the donor cells very wholeheartedly. Next, the donor should understand that it involves giving few injections for a few days to boost the stem cell count, and it may involve putting an intravenous line on two arms or in the neck to get adequate flow to collect the stem cells. And it involves a machine called a cell separator and a sterile disposable kit called a CMNC collection kit. And the procedure duration is approximately 2.5 to 3 hours. But so concisely said, the donor needs to be counseled for extensive hours, answer all questions possible, and when they come to the donation table, they shouldn't have any doubts. Like Dr. Ramanan said, no questions about finance, no questions about emotional thoughts should come to the doctor. The doctor is there to do the procedure after explaining everything. So that's the very vital piece of information.
Okay, thank you, doctor. So follow questions to this. For a donor perspective, what are when the person can start their normal life after the donation of the stem cells?
They can, most of those procedures in well-trained hands and a good setup, the complications are very, very minimal. The safety margin is very high. So within 24 hours, they can go back to work. And especially when they have peripheral venous access, it's just a question of just 12 hours rest and they can go back to work the next day. If they have a central line, especially in one of the neck veins or the thigh vein, called the femoral vein, then they need to take care for by not riding a vehicle or lifting heavy objects or driving a motorcycle, etc. They can just keep it pending for about 24 hours. And after 24 hours, they can jolly well go to work in a bike or they can go by cycle, whatever it is. But they should take care of the wound puncture site with the femoral vein and the internal jugular vein. There'll be a small puncture wound in the skin. They should clearly wipe it with an antiseptic and put a band-aid for a couple of days till the skin heals well.
Okay, okay. Well said, doctor. Definitely that helps a lot to understand what's the donor responsibility as well as how they have to take care of themselves. In fact, there is a follow-up also on this particular question. how do we see Indian donor bone marrow donor registry, doctor? So can you please throw some light? Because as far as I remember, when I was in US, I registered there, but in India, I have not done that. So what is Indian ethnic based current bone marrow registry, and how are we improving on that, building up that registry for unrelated ownership?
Given a choice, I think we all would go back to bone marrow harvest and do a HLA matched sibling transplant because the incidence of GVHD is very high. But then over the years, it has been proved definitely that the incidence of chronic GVHD, either with stem cells or with bone marrow, is the same. But the incidence of acute GVHD is certainly less. So we still encourage bone marrow harvest if the donor is willing, because ultimately the donor who has to be convinced. And if they give a consent to harvest bone marrow, we can jolly well do a bone marrow harvest for the particular transplant.
I want to interject here, sir. I'm so sorry. I think Dr. Lakshmanan, the question wasn't clear because of the audio. I think what was asked was, what is the status of bone marrow stem cell registries for
Okay.
unrelated donor donations in the country? If
India.
you could be very direct about this, I think it is very vast as a question. It is very difficult to give you a straight,
This
succinct.
particular program, yes, this particular program in India is developed very well. And there are many centers doing unrelated stem cell procedures. And we also, in Apollo, we have done, especially Dr. Revthiraj has done unrelated bone marrow harvest on a specific request from transplant centers which require only bone marrow harvesting. Is a well working network throughout the world, and all we need to do is to type in the HLA type of the particular patient, and within a couple of days we can search for the closest matches possible, and then request for a next generation sequencing for the best available donor, and that is also done. And probably within 10 to 15 days, we get a very closely matched HLA type or even a fully matched HLA type donor in any part of the world. And it is possible to ship them from that part of the world to India or from India to other parts of the world in even time so that they get the product in even time, and either they cryopreserve the product or it's ready for infusion the same day they receive the product. So this program is very well developed throughout the world.
Okay, okay.
Thank you so much.
Thank you so much, doctor.
Dr.
All right, I am going to go to the next question with some other psychological challenges. Right, again, we spoke about it. But I'm going to ask Dr. Ria one more time about the role of regular counseling during and after treatment, after transplant, in fact. It's very, very important. We all are aware of it. If you can pin down a couple of important points, that will help.
Yeah, thank you for that question. It's really important. So, some of the things that we do at our center, for example, is that we have extensive pre-BMT counseling. Sometimes, this involves mostly clarifying non-medical information, but preparing a patient for things like long admissions, isolation, how to keep yourself active in the BMT and things like that. So this helps a lot because it's not when a patient goes into the BMT, they are very well prepared for what is to come. We also regularly see them in the BMT. We encourage them to be active, do things that they like. So it could be things like reading the newspaper every day, doing a crossword, and we are there usually to, we don't just tell them to do it, but we make sure that, they do it. It could be listening to music. Sometimes it could be, even things spiritually like praying or, things like that. We have a discharge counseling session. It's also with the patient as well as the caregivers, so that they understand what they should be prepared for once they go home. Sometimes things like, they feel that once we go home, we don't have to come back to the hospital, right? So preparing them for the fact that it's possible that you may need to come back, but it's okay. How can you be safe in terms of basic infection precaution, things like that, and slowly getting back to normal. So we encourage some form of exercise at home, doing yoga. So we have online yoga classes. So we continue to see them well post their treatment as well, until they go home to their hometowns. And even then, if they wish to follow up, we do that. We have a thing we call a survivorship clinic. So once a year, we usually call them and check on them and see, how they're doing. So all this helps, significantly understand any psychological difficulty that they have, so that we are able to address it early. If there is any worry, any fear, anything that comes up for a patient, we are able to identify it early and kind of, work with the team to find a solution to whatever the problem is.
Okay, that's really heartening, Doctor. Because I was going to ask you how frequently, once they are well, we are going to monitor at least once in a year. That's a good thing to do, definitely.
Yeah.
Thank you so much. And I'm going to ask certain questions to Dr. Jasmeet Kaur. So, from a real experience perspective, now I'm coming to the pathology side of that. So maybe this question is like, bone marrow transplant, post bone marrow transplant, is chimerism test enough to monitor disease, or does one need regular RQ-PCR?
Yeah, so post-transplant chimerism is the best method to monitor engraftment of the donor cells. It is also the best method to monitor the engraftment after it has been documented that engraftment has happened. But chimerism is not a tool to monitor MRD.
Okay.
It has to be supplemented with an RQ-PCR to look for return of disease.
Okay.
Chimerism is only a tool which says donor cells have increased, become 100% in the recipient, or they have become 100% and are decreasing for 100%. And the other thing one would have to also use chimerism for is to see if you have given DLI, a donor lymphocyte infusion, which we spoke about earlier, then to monitor the response of the recipient chimerism status to the DLI, but definitely not a method of monitoring MRD. At best, a surrogate marker, but not itself MRD. At least not as of now, how we do it by the STR method on the DNA sequencer. But yes, when we move on to the NGS and others, it would also help with the MRD part as well.
Okay, okay. Definitely one need RQ-PCR along with it. So relevant question to you, ma'am. What's the difference between blood and bone marrow RQ-PCR test?
So when you do a test, this is true for RT-PCR, the RQ-PCR, but it's also true for most tests. When you do it on one sample, that is, if you take a peripheral blood sample, you should continue repeating it on the peripheral blood. Or if you're going to do it on bone marrow, you should continue doing it with bone marrow. As far as the peripheral blood is concerned, it shows a significant higher rate of the transcripts as compared to the bone marrow. So to call something a molecular response on peripheral blood is more stringent than it is on the bone marrow. But the real important point here is that if you're taking one particular type of sample, it is better to continue with that particular sample. And should you be wanting to switch from monitoring on peripheral blood to bone marrow, this information must be made available to the person who is interpreting the result, who will have to take this into consideration while giving out a result to this particular test.
Okay, that gives more clarity. Thank you, ma'am. Right. My next question, definitely a lot of information I am also gathering now. My next question is to Dr. Prabhas Mishra, Dr. Ramanan also. Will I require further therapy with TKI after the transplant, and for how long?
Sorry, can you repeat the question?
I'll do that. Will I require further therapy with TKI after the transplant, and for how long that would be?
So generally in my practice, I do advise for starting a TKI. Generally, I started at 3 months post the transplant. And in these cases, because they have been transplanted, because they had progressed, I would prefer to continue them lifelong. Quite often, this becomes a challenge because they are already suffering from GB effects of transplant, GBSD, and other issues, in which case starting the TKI does become a challenge. But otherwise, in my practice, my aim is to start with TKI post transplant. I started at 3 months post transplant and continue it for lifelong. This practice, I do understand, might differ from center to center, and there are people who don't give a TKI post maintenance. Some people do give TKI for a limited time post maintenance, but these variations would be there. I would be happy to understand what other centers do, if possible, from Dr. Ramanan.
Okay, that's good. Is there any more inputs to this particular one from others? Please.
Yes, I agree with Dr. Mishra. It is a part and parcel of treating patients with CML. It makes life very easy, both in terms of controlling graft versus host disease and in terms of controlling the disease itself. And of course, there are practices which various centers follow depending upon the patient stage as well, the patient's RQPCR levels over a period of time, the patient tolerance to the TKI, and also overall data supporting the duration of TKI, even involvement of central nervous system with the CML in advanced stages. So there are so many other variations to use of TKI. But having said that, TKI treatment post transplant is a necessary treatment, as Dr. Mishra has already explained. We can move to the next question.
Thank you, Doctor. Yeah. So I have one more question to Dr. Mishra. Relevant to this, Dr. Ramanan talked about conditional therapy. What is conditional therapy and how will it affect my body? My future as a parent. Very, very important question for most of the people. So if you could throw some light on that, would be helpful.
Sorry, I can take that question if
Sure.
there's sure.
Sure,
So I think
Yes.
the first part is what is conditioning therapy and how will it affect my body? It has been covered in wonderful length and breadth previously. And so what is conditioning therapy? You need to empty your bone marrow from all your cells so that there is space for the new cells to come in. So that is what is the job of a conditioning therapy. And it does involve drugs which are otherwise considered chemotherapy. So this is going to reduce your blood counts. This is going to cause breakage in the mucosal tissue. So you might have oral mucositis. You could have loose stools. These are during the time when your blood counts have not improved. So because your counts are low, you would be at risk of getting infections. This is, of course, the immediate effect, but that is a very necessary thing to be done. Otherwise, we will not be able to do the transplant. However, in the long term, my future as a parent, so obviously some of these conditioning regimens will have long-term effects. They could have long-term effects on the lungs, skin, liver, heart. And yes, as a parent, so the specific question is whether if fertility is affected. Yes, fertility could be affected. And there is a very strong possibility that you might not become a parent. So for males, you may suggest getting a sperm donation and cryopreservation. For females, oocyte preservation can also be done. This is the first question that is there on the slide. Would you want me to answer the second one as well?
Absolutely, that will help. Doctor, I think we may have a few more.
The other question is, what is GVHD? How is it prevented and treated? And how does one know if one is at a high risk of getting a GVHD? So GVHD is essentially graft versus host disease. So, ultimately, even though you are using a graft which is completely or fully matched, in most cases, it would be fully matched, whether it is a fully matched sibling, it could also be a fully matched unrelated donor. And in some cases where you are not getting either of the two, you may then consider a half matched or a haploidentical donor as well. So when you are infused these stem cells, ultimately these are foreign to your body, and because of all the chemotherapy and the immunosuppression that you are being given, it is very likely that your body is not going to mount a effect against these against this graft, so they might act against your body. So this is called a graft versus host disease, and it can manifest in various ways. In the acute phase, it could present with diarrhea, and in the chronic phase, it could present with skin problems, lung problems, liver problems as well. Long-term musculoskeletal effects can also be there. So how is it prevented and how is it treated? So to prevent it, we give drugs like cyclosporin during the transplant. Many centers have started using post-transplant cyclophosphamide, not just for half-match transplants, but they're also giving it for fully matched transplants as well. In patients who are getting an unrelated donor, in those patients, we give a drug called anti-thymocyte globulin, preferably the rabbit variety. So these are the drugs that are given to prevent the GVHD. And generally, you continue with one of these drugs like tacrolimus or cyclosporin or mycophenolate for at least 2 to 3 months, and then you taper them off and stop them. How do you treat them? So for particularly if somebody, despite all of these measures, somebody does get a acute graft versus host disease, the treatment of choice that we generally do here are something called steroids. So we start steroids with high dose, and then if it does not work, then we also use a drug called ruxolitinib. This is for the acute phase. And similarly for the chronic GVHD, we again use drugs like steroids, we use ruxolitinib. If somebody has got the effects in the lung, then we also use inhalers and other drugs for those part as well. And the last question within this particular question is, the last part is, how does one know if one is at a high risk of getting a graft versus host disease? So when we start with a transplant, we do see whether somebody is old. So older people, older donor or an older recipient, both are a high risk for a GVHD. If there is a gender mismatch, that becomes a high risk for GVHD. There are some studies which say that if you have got a blood group mismatch, that might also be at a high risk of GVHD. People who have got a haploidentical transplant or a mismatched transplant would be at a higher risk of getting a graft versus host disease. People who are also had a lot of infections during the transplant period, have got lots of antibiotics, again could be at high risk of graft versus host disease. But as you might well imagine, we don't always have the luxury of choosing a donor or the age at which we need to do a transplant. But yes, there are certain factors that as a physician, we would like to know at the outset if somebody is at a risk of getting GVHD.
Very, very detailed explanation. Thank you so much. Dr. Venkatesh, we have time for one more question.
I'm really sorry, but we are really completely
right.
out of time. Dr. Prabhash Mishra has so wonderfully kept it so much to the point and yet explained in great detail about both these questions. And I think I'm afraid I have to stop here and we move on to the end of our program, where I get to heartily thank all of you. I'll start with Mr. Nagendran, who has taken the time and the effort to bring all together on this ISBMT platform from Friends of Max Foundation. I thank all the participants who have witnessed this webinar, and I sincerely thank all my esteemed panelists for sharing such valuable insights, such vast experiences, and taking their time out to address patients directly on this in this wonderful opportunity that ISBMT has created to address the patients through this patient support program. I welcome all of you to our next webinar, which may happen as a in-person webinar, as an in-person meeting and the ISBMT platform between the 3rd and the 4th of May. Stay tuned for further updates regarding the same. And I again thank everyone for joining this meeting and making it a success. And from all of us here at ISBMT, the organizers, Jolly Madam and Nirav, and the ISBMT office bearers, thank them for this opportunity, and I declare this meeting as closed. Thank you so much.
Thank you.
Thank you.
Thank you.
Dr. Venkatesh.
Thank you.